So hello everyone who's here. Welcome to the Voluntary Center for Molecular Medicine's Clinical Arena Lecture Series here at Linköping University. I'm Rosalind Simon. I'm a senior lecturer here at LIU and the assistant director of LIU's Research Graduate School Forum Scientium, and I'll be hosting today's arena. So the central aim of the WCMM arena is to highlight these sorts of collaborations between researchers from the Faculty of Science and Engineering, Medicine and Health, and Linköping University Hospital. Today, we're honored to introduce our two esteemed voluntary research fellows, Rolf Saager and Chris Anderson. Rolf is a senior lecturer and docent here at the Department of Biomedical Engineering at Linköping University in Sweden. He's a research fellow at the Voluntary Center for Molecular Medicine, and his research focus is in biomedical imaging and spectroscopy. He received his PhD from the Institute of Optics at the University of Rochester with a specialization in biomedical optics, and has worked as a postdoc and a project scientist at Beckman Laser Institute and Medical Clinic at the University of California in Irvine, focusing on the development and clinical translation of several quantitative imaging techniques. And in collaboration with Rolf, today we have Chris Anderson. He's originally from Australia, but he's been working here in Sweden as a dermatologist for most of his professional career. And he's now an emeritus professor studying skin physiology, microdialysis, and multiparametric skin physiology, as well as eczema and barrier function. Welcome to you both. And now I'm going to hand it over to Chris.
Okay. Thank you very much for this opportunity to speak to you all. I'm going to try to tell you a little bit about how I have worked and how I work and how it became relevant to work with Rolf. And we decided today that we'd talk about the background of the skin's innate reactivity and how that impacted on something which is very current at the moment, a new method of vaccination called microneedle vaccination, in which the vaccine is dry coated onto the microneedles and applied to the skin. So we'll get into some of that, talking a bit first about what is innate reactivity, and then the details of how the vaccination looks and why it's interesting. So if I have any affiliations to declare, it's that I think that the skin is a fantastic organ. And here I show a picture of the epidermis abutting the dermis, and the epidermis has been stimulated with UVB, which makes the little dark cells, which are called sunburn cells and apoptotic cells, producing cytokines which affect the capillaries. And the capillaries are something that we have we're quite good at measuring the content of capillary erythema. And when you come to what is the skin's innate immune response, well, the immune response is usually thought of as being very focused, but there is also an innate immune response which we have inherited phylogenetically and had for a long time. And there are three phases to it. It's sort of an antimicrobial phase, an inflammatory response, and then the interaction on the adaptive immune system. And it's usually thought of as being something which bacteria do. And most of the literature has to do with TB or some other bacteria. But in fact, things like non-microbial activation in the form of irritation or venom or UVB and trauma are potent stimulators of the immune system. And this has come to be relevant in one of our applications now, the vaccination application. So we are born with the innate immune system, but it didn't come up overnight. So over 2 million years on the savannah, we learned how to train our immune system. And there were these typical things like sunlight and noxious plants and venom and trauma, which is current the item of what we'll talk about today, and also our microbiota, bacteria that we've learned to react with. So as we were running across the savannah, we were being faced with all of these threats. And the way I play with it is that Aristotle said that everything has a purpose which it is trying to fulfill. And that's called teleology, not theology, but teleology. And the things which are threatening us, I like to think of as dumb, not very thinking. What is clever is our mechanisms in the skin, which teach us or have taught us over the years to react to these threats. And the reason we react is because there's some sort of survival value. But anytime there's a survival value, there might be a negative consequence. And so the negative consequences might be left for us to deal with, where the positive survival value is no longer apparent for us. So I call teleodermatology addressing the question of why does this happen? And just with the micro trauma, the survival value is that if you react when you get the micro trauma, you prepare the skin to respond to microbes which might come and multiply. It's also the necessity for regeneration is initial inflammation. So to get healing going, we have to have trauma. And also the induction of the physical response actually has turned out to be what we call an adjuvant. It helps the immune response. And in this case, we're going to talk about vaccination, microneedles, and getting an immune response to whatever we're vaccinating against. So the downside is that it might be abnormal healing. Unfortunately, this isn't that common, but it can occur. You can also get secondary infection, and you can get scar formation. So this yin and yang of reactivity. And what we've liked to do in our lab is to look at the cartoon of the skin with the epidermis, the dermis, and the subcutis. Think about the ways in which rubor, calo, dolor, tumor, and loss of function are produced, which are the classical signs of inflammation. And the thing that I'm really interested in is microdialysis, where we put a little catheter into the skin at about the level that the cartoon shows and measure either inflammatory mediators or things penetrating from the surface of the skin down there. So when we look at it in a joking fashion, instead of going to the window to look at what we want to look at, we look at the TV of it, and outside in the window, you've got rubor, calo, dolor, tumor, all these things. But we try to think of the skin structure. We measure with our eyes how much reaction there might be. We measure with machines like the tissue viability imaging. We can measure evaporimetry and impedance. So we have skin physiological tools that we can measure. And what we can measure are typically provocations, like actually putting the catheter, the microdialysis catheter into the skin, or putting a lancet through the skin. At the end of the experiment, we can take a biopsy, and what we call an endpoint biopsy. Now, in the terms of vaccination, before 2020, global vaccinations were already existing, and they talked about dermal vaccination. For instance, in polio vaccination, that costs globally $1 billion a year. So it's big business and a big undertaking of society. So from 2020 and beyond, we've got the coronavirus to deal with, at least, as well as other things. And we're going to need 2 vaccinations a year for the entire population of the world. So maybe microneedles might be an alternative, which is easier than ordinary needle and syringe. So they talk about the road to vaccination. And one of the things that we need to do, getting it from the factory into arms or into skin, is what they call cold chain. And cold chain is difficult to maintain in some countries. So microneedle vaccination is one of the advantages is that it doesn't have to be kept cold. And also it delivers right there in the dermis, which is what people call the immunological sweet spot, exactly the right spot to get a vaccination going. So the microarrays, the MAPs, as we call them, they're very densely packed microneedles. And you can see down the right here, down on the bottom here, the little map which with the microneedles on it in magnification looks like that. We apply it in some way. There's a little sort of map which has stayed on the skin for a minute or two, and then you take it off and then we can study it. So we all know that serology gives you the truth. And when you convert, you can show that this vaccination has happened. So in this particular illustration, this is normal. These are two situations in which vaccination has not occurred. These are situations when the serology has converted. And with these studies in animals and in to some extent in humans, you can show that putting the vaccine onto the microneedle is effective at a lower dose. So for some vaccines where you don't have a lot of vaccination material, this can be important. And what they showed was that the co-localization from the microneedles of the trauma and the vaccine actually had what they called an adjuvant effect. So it was responsible for making these smaller doses of vaccine compared to needle and syringe work. So finally, I see an example of the threat in form of the microtrauma producing something which was historically or even teleological important for us, combining the induction of allergy for something introduced to the skin turned into something positive. So the adjuvant of the actual trauma helped us to make these small doses of vaccine effective. And we introduced two things we'd done before, like the microneedle study and the Lancet study, microneedles in these applications, and have looked at them and tried to study them in detail. Subjectively, what patients report with a naked eye, what we can see with the dermoscopy, which is a magnified image of the skin physiological techniques of measurement of erythema, measurement of barrier damage in the form of evaporimetry. We could do it with microdialysis, although we're only in the early days of measuring that way. And tape stripping is a new method where we put a tape on the skin, take it off and analyze it. And our analytical techniques are now so sensitive that we can do it. And we can finish up with biopsy. So we have this sort of array of investigations that we can use. It gets a bit dense in the laboratory when we're doing it. So we might have 5 techniques and quite a lot of people responsible for examining this subject in the front here in the red shirt. But we had already done that, and we have reported on that, in which we can see from the dermoscopy picture, if you look on the right-hand side here, the little black dots are actually oxidized material in the holes which the microneedles established. Here we show that evaporimetry, or the evaporation of water from the barrier, goes from nothing in the normal situation. You put a hole through it and the water evaporates through the skin, and we can watch it recover over the days that we follow it. So that's useful. We can look at the erythema, and the erythema with TVI will show this sort of progression, also an immediate rise and then staying up and recovering over a number of days. So when we want to look at the vaccination categories, it might be a difference between men and women. It might be between old people, young people. And we want to know what are the consequences, and do they differ for different skin types, different ages. And we've got a lot of diseases, and the skin diseases are very common. And giving the vaccination has survival value, but there might be undesired consequences. So we've got to prepare ourselves for this rollout of going to scale vaccination. We've got a lot of people who are on different medications, and maybe the medications introduce problems, might be bleeding problems or some other sort of reactivity problems. So when Rolf and I started talking, we said, okay, well, we know what we can do. What can we do with new technique, state-of-the-art spectroscopy technique? And we've got to look for what are the information gaps. So we don't have much to do, much to say about the logistics of giving all these vaccinations. And the ultimate evidence of efficacy is provided by epidemiology, where you want to be able to say there is no transmission, there is a low morbidity, that is to say mild disease, and there's less very severe disease. Seropositivity is what you need to do, but that's a good way down the track. You know, it might be weeks before you can start interpreting that. We wanted to look at what dose are we delivering? Can we use skin physiology to help there? Can we use skin response? That is to say, is this response we see, which we're expecting, adequate to give the adjuvants to make that vaccination work for that particular person? So when we're looking forward, we're looking for how can we get and refine information that'll give us more than our TVI and more than the evaporimetry. We can even maybe have something to say about engineering of the maps, which is a fantastic process where they produce the needles and what they look like. So now we thought Rolf could talk a little bit about some of these challenges and how he interprets things that we can do. How many minutes have gone? Because I might have to get back to the cartoon. I'll show it to you later and leave time for Rolf to get on with his bit.
Okay, so thanks, Chris. So yeah, I'll just jump into my part of this talk. And again, you know, Chris had a very nice setup and the motivation behind the microneedle vaccination approach, what the advantages are, but since it is such a radical new approach, there's a lot of questions as well. You know, the idea of not having to have it under extreme cold temperatures when delivering it. It's a dry coated process, but also the main interest of this is the fact that the dosage can be much smaller potentially from this microneedle approach, so allowing far more vaccinations to be produced from the same batch. You know, has a lot of advantages, but the severe consequences is, well, if it doesn't take, then it's an ineffective approach. And how do we maintain some sense and some ability to, you know, have some kind of biomarker to show whether the dose delivered was in fact sufficient for each patient? So let's see here. Oh. So basically for this half of it is really trying to look at now, how do we establish some metric of skin reactivity when these patches are being utilized? So, you know, the one thing we really want to consider is, you know, can we characterize a physiologic response from the resulting microtrauma from these microneedles? So again, this adjuvant approach and mechanism that Chris was talking about. But, you know, in addition to that, we need to consider a lot of other factors. So we need to account for physiologic differences across a broad population. Will this adjuvant effect be the same across different populations? Are there different considerations? Should there be different designs of these microneedles for different types of populations? So, you know, we need to have a way of trying to assess the inherent reactivity across the broad population. You know, not everybody will have the same response, but also from our measurements, you know, we need to also consider the impact of unrelated factors. So skin pigmentation, you know, typically, you know, we're looking at optical effects. So any type of pigmentation will be a confounding effect. We need to address that. But age, gender, as Chris already said, and then lastly, you know, the health status of the patient, you know, what complicating diseases or afflictions. So, you know, with Chris's expertise in eczema and how might that already impact the delivery of the vaccination when, you know, the skin is already under stress from other factors, and then the impact of medications as well and how that might affect the delivery. So As I mentioned, our group here is looking at these quantitative optical imaging techniques and optical spectroscopy. So, to give a little bit of a background and step back, just to give a broader context of what we do, the first thing I like to start off is just ask the question of what happens when you shine light into tissue. And there are three main effects that the techniques that we're developing here really try to address. And the first is scattering. So when light comes in, so again, if this is tissue, you have various objects within tissue. Light will enter the tissue. It can bounce around and deflect off of different objects, and that's what's referred to as scattering. And the kind of interesting diagnostic aspect of scattering is the fact that it's sensitive to the size and density of subcellular and extracellular components. So light will scatter slightly differently for different size particles, but typically it's sensitive to mitochondria, lysosomes, and vesicles, but also striations in collagen, membranes, so on and so forth. And what we ended up getting is, as a function of the wavelength of light that you shine into tissue, there is this spectral response, typically characterized as a power law, but the shape and slope of this scattering spectrum is related to the size and density of objects. The next thing that you can encounter in tissue is absorption. So here light enters, encounters a molecule, the energy from the photon gets absorbed, putting that molecule into a higher excited state. And there are various common chromophores in tissue where absorption has a dramatic effect. And so that's hemoglobin, melanin, lipids, and water. And so again, here, as a function of the wavelength that you shine into tissue, you will have a differential response in terms of absorption from these different chromophores in tissue. And lastly, you have fluorescence, where here again, essentially it's an absorption event. But in the case here, when the molecule goes into an excited state, one of the options is that it can remit the photon at a slightly different wavelength. And typically these things that will fluoresce in tissue are collagen, elastin, or NADH, FAD, so cellular metabolism components to that. So with all these different mechanisms in mind in terms of tissue, there's a lot of different types of diseases or afflictions in tissue that could be addressed by the combination of these different effects. So for example, melanoma, epithelial cancer, burn wounds, so on and so forth, that you have this kind of combination of different things you are sensitive to, both in terms of absorption and scattering. So, that's really exciting. Light is sensitive to a lot of different physiologic parameters within tissue, but the question now is what do we actually see? So when it comes to shining light into tissue, what we only see is what comes back out. So what happens within the tissue is still a little bit of a mystery. We're not sure when we see light coming back out of tissue, where did it actually go? What really happened to it along the way? We just have this ensemble average of accumulated effect as to what the output is. So, the question really here is this really useful? And so there's a lot of challenges, particularly in skin, as it is a structured tissue in depth, is how do we isolate these features and become more specific? Because again, we are sensitive to a lot of different things, but we're not necessarily specific when we utilize these types of optical techniques. And the main root cause for this is this scattering effect, because since you have light randomly rattling around in tissue, it becomes very difficult to discern the localization of where these absorption effects happen. So we know that you have absorption occurring, but where in the tissue? Is it a high concentration of an absorber at a specific depth, or is it a low concentration distributed throughout the entire volume of tissue? Likewise, with the scattering, since it is this kind of power law spectra, where it's this nebulous, density and size, mean size of objects, localizing what the specific scattering properties within different compartments of tissue becomes very difficult. And so in sense, the problem is that we don't necessarily have localization or specificity in terms of these scattering components. So that has been a kind of classical challenge in terms of this diffuse optical techniques. And what our group has been developing is this spatial frequency domain imaging technique to try to address these main technical challenges. So here, the technique itself is essentially shining different patterns of light onto tissue. And the concept behind this is essentially when you shine different patterns, the absorption will just attenuate the photon, but the scattering will blur out the pattern itself. So we have two different kind of sources of contrast to really discriminate absorption from scattering. And so what we can see here is that in terms of a experiment where we have constant scattering, but we change the absorption, we can see that as we change the frequency of the pattern, going to increasing patterns, we can see that changing the absorption will change the curve, this attenuation of the light coming back out. Whereas if we keep absorption constant, but change the scattering, we have a different curve. And so what we can do is develop these models of light transport and fit these different types of responses, and now separate absorption from scattering, which is the first main goal that's very challenging to do. So now we can go through and look at absorbers in the context of other absorbers and scatterers in terms of other scatterers. The other benefit of this technique is that as we're shining these patterns of light into tissue, based on the frequency of the pattern itself, as scattering blurs out the pattern, our sensitivity as a function of depth is also varied. So different frequencies will actually probe different volumes of tissue. So we have the ability to discriminate absorption from scattering events, but also the ability to differentiate in terms of depth. So this is the kind of core of what our group has been developing in different directions. But this is kind of how we are approaching this question of how do we quantify this skin reactivity. So for the initial experiments that we've been doing in the context of this microneedle vaccination, we have this technique called spatial frequency domain spectroscopy. And essentially what it is we have a projector. So a digital projector here that will shine different patterns. So it's controlled by the computer, so we can actually vary the different patterns of light. And then what we do is we collect from a small area in the center of this field of view and send that light to a spectrometer. And what we get are now these absorption and scattering spectra from the visible to the near infrared. So here we can see in the absorption spectra, this double peak feature is related to oxygenated hemoglobin, whereas with the scattering, we have this power law-like relationship that will inform us about the size and density of particles. So using that as a platform, we've done some very initial pre-pandemic studies on healthy subjects using these microneedle arrays, where we would measure in the area of the applied microneedles and also an adjacent area just to get a relative context of what the skin optical properties look like. And this initial study was 6 subjects with a mean age of 40 years old. We applied the patch to the lower forearm, and these were non-vaccine coded patches. So these were just blanks. So here we are just looking at the skin reactivity in terms of the microtrauma. And what we did would follow the changes in the patch area versus the adjacent area from immediately after the application of the patch to 30 minutes, 2 hours, day, 2 days, 4 days, 7 days out. So we can get this kind of progression over time of what are the physiologic changes that we can measure from these optical techniques. And this is the work that was done by one of my researchers, Hanna, and Joachim Henriksen, who is from the region. He's a medical engineer. So they went through and did this initial study, and I'm just going to present some of the initial results from that we found. So the last part of it is, now that we can collect this data, what we're really looking at is how do we try to characterize the skin reactivity at different depths. And again, to elicit what is the patient-specific response to each patch. So the nice thing about this spectroscopic approach is the fact that in visible light, the depth penetrance of photons is actually very superficial. And so usually we get around 300 to about 600 microns penetration depth from that light, whereas the near infrared light can penetrate a couple millimeters into tissue. And so what we can do in a very first look type of approach is actually try to identify absorption and scattering events in the visible. That would be related to superficial physiologic changes, and then also look at the same chromophores and scattering effects in the near infrared, and that would represent the deeper tissue. So here again, looking at these different parts, we can fit for hemoglobin, melanin features in the visible, but we can also fit for them in the near infrared. And the only difference between these two different regions are the volume of tissue that we are interrogating from this technique. So to get to some of the preliminary results, when we're looking at just the oxyhemoglobin and deoxyhemoglobin changes, which we can fit, again, the blue is the superficial. This is using visible parts of the spectrum. And the red is using the near infrared parts of the spectrum, which is penetrating about 3 millimeters versus 600 microns. What we see here is that, again, we can see a large change in the superficial oxyhemoglobin relative to the deep tissue. So there is some response that we can see, and we know that that response is confined to the superficial layer, the 600 microns of the tissue. And likewise with deoxyhemoglobin, there isn't that much change, but again, that's something that we would expect in terms of looking at the hemodynamics in terms of response to trauma. The fact that there really isn't that much change, it's primarily this vessel dilation and blood going towards the damaged area. So here, the main take home from this very preliminary result is that we see an increase in oxygenated hemoglobin in the upper part of the tissue. So in the region of where the microneedles have kind of penetrated the skin, we have a response in terms of hemodynamics. Likewise, when we look at tissue oxygenation, so this could be used as a surrogate for metabolic activity and cellular activity in the tissue itself. The question that we had was, is there a global response to this insult, or is it highly localized? And what we see here is, again, in the red, now we're looking at the region. Again, this is the visible light spectrum, so this is superficial tissue. Red is in the region of where the microneedles penetrated, and black is in the adjacent area, about almost a centimeter away from where the patch was, to look at a kind of global versus local response. And what we found here is the fact that there is a very short-term global response, but there is a larger response and a more sustained response in the area of the trauma itself. So these are kind of the initial findings we're building off of what we can see from these optical spectra. But then, as Chris had alluded to, is, we really want to see is what is the variance amongst different population groups. So, these are healthy individuals with a mean age of 40 years old. What about looking at an older population? So while this was occurring, they also had recruited 6 subjects with a mean age of 73 years old. And in this cohort, again, very preliminary data, we can see in terms of the oxyhemoglobin response is the fact that the blue being the superficial, red being the deeper tissue, is that there is some response, but relative to the healthy cohort, it wasn't as dramatic as a response. So we can see that in older populations, this reactivity is somewhat diminished from this, at least potentially from this. And also what we could see is that the response, the return to normal, is much quicker than we see in the healthier population. So, there are 2 different things going on that potentially in an older population that might need more work to elicit this adjuvant effect, as in a healthier, a younger population, but also that the response time is not as dramatic and not as sustained in this fact. So, just to kind of keep this short and wrap this up, since it's very much preliminary data, is that, where we started was looking at the oxy and deoxyhemoglobin changes at depth to try to get a sense of how can we correlate this to skin reactivity, but that's not all that we can do. So, talking about inflammation. So what about water content? So, that was also one of the goals. But if we look at the spectrum here, there is an absorption feature for water. However, it's way out here in 970 nanometers. It's a very weak response. And also it's challenging from an engineering standpoint because light sources and sensors at that wavelength are also really poorly performing. So this has been something where we have redesigned the system that we had shown. So now we have much better and much more reliable sensitivity in this wavelength. But of course, thanks to the pandemic, we haven't been able to utilize this on any clinical subjects. But that's the next plan, to really characterize inflammation in terms of water fluctuations, but also really now getting into the structural changes in terms of the scattering. So similar to what was done before with the absorption, if we look at scattering in the visible, we know that that is going to be derived from more superficial tissue, where in the near infrared, it's going to be the scattering effects accumulated over a larger volume of tissue, that we can start to differentiate and look at inflammation in terms of the swelling of cells and extracellular compartments to say what is the size and density changes in the structure of skin. So, and then ultimately the goal is really to look at, whether these changes are different in vulnerable populations, age, gender, ethnicity. There's been a lot of literature regarding these microneedles where there's somewhat inconsistent results, but there's some literature that actually say that skin pigmentation may have an impact on this as well. These are all valuable questions that we really need to kind of explore and understand what is the variance, what is the source, in order to really aid in this patch application design and optimization. So are the number of needles sufficient? Is the density sufficient? Is the length of the needles, the penetration sufficient to do this? And how might we be able to inform how to develop a single patch that would address the needs across a very broad population? But the other interesting part is potentially with developing this kind of skin reactivity metric is the fact that we can also develop simplified spatial frequency domain imaging systems that can be used at point of care. So these low cost, simple systems as a means to monitor and verify to say if this is going to be implemented and in its very early stage and that an actual vaccine is delivered by the patch, can we also then monitor and image that over time just to verify, yes, in fact, patch was delivered and there is a patient-specific response to this, and verify at the point of care to make sure and ensure that should a patch be misdelivered or there's a limited reactivity, that an additional corrective measure could be made at the point of care. So those are the kind of main goals that we have and that we're looking forward to actually trying to collect more data based on that. But that's all that I had to share. And I guess at this point, we will open it for questions.